support us. And so, Monique, I'm going to throw it over to you.
All right. Well, awesome. Jacqueline, thank you so much for having me. I really want to thank you all for letting me be in your very safe space. And this is a beautiful chance for you all to support each other. And thank you for allowing me to be a part of that. So I am Dr.
Hold on. Hold on. Okay.
Okay, yeah, okay. Yeah. My name is Dr. Monique Nugent. You can call me Monique throughout this, and I want this to be a conversation. I am a board certified internist who practices as a hospitalist, meaning I only see patients who are acutely hospitalized. You cannot make an appointment to see me. You don't get to choose to see me when you come into the hospital. I am just the friendly face that shows up that at the time that's often the scariest and sometimes worst point in somebody's life. I'll give you guys more about my credentials later, but I will tell you that I have been doing this almost 20 years in hospital medicine, very much dedicated to improving the experiences and safety and equity of the care we deliver in hospitals. And now I speak to the community to teach you all the skills that you need to be active participants, to be drivers of your care, to be the advocates that your loved one needs so that you're also a partner to make sure that you're getting the best care that you possibly can and your loved ones are getting the best care that they possibly can as well. So again, thank you for having me.
Absolutely. And there will be a Q&A segment once the presentation has finished. And so you guys will be able to ask all of the questions that you have. Um, going to share my screen for a second. And all right. Those closest to us won't understand every season of our lives. And while technology is improving, it doesn't understand what regular loss feels like. I am Jacqueline Revere. I created Mom of My Mom, a digital diary where I shared the journey of caring for my mom through her dementia diagnosis. Along the way, the New York Times coined the term carefluencer to describe the work I've done to normalize what care looks like. But knowing what caregiving looks like and knowing what it feels like are two very different things. For many, that feeling is hard to put into words. As an only child and solo caregiver, losing my mom forced me to reflect on what I needed most during my journey. And the answer I kept coming back to is community. So years later, I partnered with a therapist, friend, and former dementia caregiver, Lynn McGuire Raj, to create the Care Den. The Care Den is an online facilitated membership community for caregivers. We gather daily, not just to talk about our loved ones, but to explore our hobbies, share insights, remember who we were, and imagine who we're still becoming. Yes, questions about care are welcome, and we'll find the answers together. But this space is for people who need support, connection, and room to breathe, a place to feel understood and get cozy and find resources and laugh a little and sit with the complexity that caregiving brings. Every stage of care is welcome. And my hope is that here, you don't have to carry it alone. So please join us in the Care Den.
Thank you. So I'm going to share my screen really quickly. And then I'm going to explain to you about. So this talk is going to be a really high level talk about what I, as a hospitalist, somebody who's been doing this, like I said, for going on almost 20 years, want you to know about coming into the hospital, how to keep your loved ones safe. And also these skills also are applicable to you, right? So I was telling Jacqueline last night, I jokingly call the hospital the DMV of healthcare, right? You're going to end up there at some point in your life. You are not going to be happy about being there. And you are going to feel like you're going to get the runaround. So the point of this presentation is to give you some skills, lay some foundation so that you're not feeling like that way, that you feel like you can pump the brakes a little bit, you can exert some control. There will be a question answer after this. So please keep your questions in mind, write them down in the chat, and we will get rolling. So again, I'm Dr. Monique Nugent. Please refer to me as Monique throughout this conversation. Again, board certified internist, and I love hospitals. I know that's a weird and horrible thing. Sometimes people say, like, why would you say that? But I get to treat people at the points when they need me the most. I get to be invited into people's families at really intimate times. And that is something that I really cherish and I take as a huge honor in my practice. And so making sure that people are safe, are heard, are supported is really what my calling is. I don't have a lot of information on the slides because this is about talking. So whatever you see there, take as a guide. So when people come to the hospital, these are the words that they use to describe their experience. Intimidating, scary. This one I hear a lot, triggering, right? There's so many things happening. Fearful, expensive, right? That's something we cannot forget in this country. This one, unexpected. How did we get here? I don't know what happened. Suddenly, mom was on the floor. Suddenly, dad couldn't breathe. This was an unexpected thing. We were not prepared. The experience was frustrating. I had to repeat myself over and over. They seemed to lose every single piece of paper. I felt like the left hand wasn't talking to the right hand. These are the common experiences that people have. But somewhere tucked in there, people do find relief. People may be happy, even if it's not the one they want, but to get a diagnosis, get some questions answered, right? They will find some hope every so often in a conversation, in a warm hug, in a doctor's discussion in a hallway, right? This can be a place where you find care. This can be a place where you, as caregivers, can find some relief. But this requires planning. So, how do you do that? The number one thing I want all of you to take away from this conversation as caregivers, before you end up in the hospital with your loved one, you must put in the effort and time to set up the medical legal framework and the social support framework to support you in a hospital stay. What does that mean? You care for your loved one, but are you their decision maker? That is a question that will get posed to you during a hospital stay. I, as the attending physician, may not know who to call. There may be complicated family dynamics as to this sister you can call, that brother you can't, right? There may be social support networks in religious institutions that I am unaware of. There may be financial constraints on who can make decisions and where people can go. If you have no medical legal, meaning the medical paperwork and the legal paperwork that work together to tell me who you are and how you are caring for this person, you may find yourself shut out of decision making. You may find yourself not getting updates. And this, I know, trust me, I know that this is the single most frustrating and oftentimes dangerous thing that can happen for caregivers. I used to be the associate director of a hospital medicine group of over 100 physicians. One of my major roles was to field complaints from families. So you would think when family members complain to the hospital, take their time to write an email to the CEO, to write an email to patient advocacy. It would be something like, I didn't like how I was, spoken to. this wasn't safe, the room wasn't cleaned. But the number one complaint I got was lack of communication or communicating with the wrong person or not believing that somebody was a healthcare proxy. You need to take the time with your loved one, if they have the capability to make these decisions, to sit down and have a healthcare proxy form completed. This says, I want my daughter, Jane, to be the person who makes medical decisions for me if I can't make those decisions myself. Right? A healthcare proxy is not a durable power of attorney. I'll say that again. A healthcare proxy is not a durable power of attorney. Durable power of attorney is a legal and financial thing. A healthcare proxy is a medical legal thing, right? So these don't have to be the same people. And oftentimes I'll see family members where they're not the same people for different reasons, right? But if you're operating on the idea that I currently am my loved one's durable power of attorney, so if they're hospitalized, I will get to make decisions. I'm so sorry to tell you that is not the case. Take the time to sit down and complete a healthcare proxy form with your loved one so that they deem you, their caregiver, as the person who can make decisions for them in a hospital. The second piece of paper you're going to fill out is an advance directive. These are two different pieces of paper. An advance directive, I'll get to you in a second, Kimberly, and a healthcare proxy. An advance directive is also what people would call a living will. It's where people write down all the things that they want. Yes, I would do dialysis. No, I wouldn't do dialysis. Yes, it's okay to keep me intubated for 5 days, but after that, reconsider. I would like to be turned into, one of those Disney cryo pops and have everything possibly done, right? I have seen advanced directives be very specific. I have seen advanced directives be very vague. Ask Jane. Jane will know what to do, right? But the point is, an advanced directive is more of your loved one's explicit voice in what they want in their care. And this document will speak for them if you are not there. This document will back you as a healthcare proxy up when it comes to making complicated decisions because you already have their voice. And the reason why I'm spending a lot of time on these two documents, is this document, the advance directive, will protect you, the healthcare proxy, when there are difficult family and social dynamics. If you have an advance directive from your loved one where they explicitly say what they want, and you as a healthcare proxy are carrying these things out, it makes that consistency much easier to support your decision-making process. These two pieces of paper are not hard to fill out. You can fill them out in the hospital if needed with a social worker or a case management manager. If you have an elder care attorney who you're working for, that's an even better person to spend time with. But take the time, if your loved one can make the decisions, to write these things down. Take the time to fill these out. And then you're going to get copies, and you're going to put copies in your files, on your fridge, to your primary care doctor, to the hospital, everywhere possible, because you do not want to be left out of the loop because people don't know who you are and what your role in your loved one's care is, right? So that's a lot, but these two pieces of medical legal paperwork will set you up for success. The next thing you're going to fill out is a MULST or a PULSE, depending on the state that you live in. This means mobile order of life-sustaining treatment or portable order of life-sustaining treatment. I'm going to click on this link and it's going to take us to the state directory. I want you to go to pulse.org and find your state. and click on your state, and it will give you the exact documents for your state. I live in Massachusetts. In Massachusetts, it's a bright pink form. This bright pink form is essentially the same medical orders that I, as a physician, will need when your loved one comes into the hospital to say, would they want CPR? Would they want intubation, which is a tube down the throat, and put them on a machine if they can't breathe for themselves, right? It is that exact wishes explicitly from the patient and their caregiver written down for me as a medical order. In these here United States, this is the only medical order patients get to write. After this, I write everything, Tylenol, bathing, all of those things. But this medical order is an order from you and your loved one that explicitly says your wishes. Again, after you fill it out, put a copy on the refrigerator. In every file, primary care doctor will have it. Make sure the hospital has it. And don't be embarrassed to bring it with you. You want to make sure that their voice is always respected. That is the most important thing that we can do in a hospital stay. I I got to make this big again. Give me 2 seconds to stop sharing and then make it big again. I apologize, guys. We have one question. No. Okay. All right. The other thing I want you to do is figure out who your social support networks are as the caregiver. A hospital stay is rough on the patient, yes, but it's also really rough on you. The average hospital stay in this country is about 4 to 5 days. And that is not 4 to 5 days of respite. That is not 4 to 5 days of downtime. That is 4 to 5 days of a lot of decision making, of coming back and forth from the hospital, sometimes spending the night in the hospital. You need to survive this too. You, as a caregiver, need to come out on the other end. So if you have social supports who can sit with your loved one in the hospital, if you have someone who can meet you at home when they're coming home, if you have someone who can give you a break, take that. Take that. Let people show up for you as best as they can. So let's talk about the days of a hospital stay. Why this isn't making any bigger. You guys are seeing my 10,000 tabs and getting a view into my madness. So welcome. So I've written a book, and this talk is very much based off of this book. This book is called Prescription for Admission. Jacqueline has it. You can find this book on Amazon, anywhere that you buy books, Barnes and Nobles, things like that. And so this talk is very much based off of this book, where you can get most of this more of that information in depth. And that's one of many resources I have for you. But day one of your admission is what I call the stabilization and admission day. The day where I, as a physician, are making sure that all the dangerous things are taken care of. Low blood pressures, fevers, confusion, infection. Things are moving fast this day. This is the day that you're in the emergency department, where you're going to meet the emergency department physician. And they're going to do all of the things, lots of IVs, calling specialists, making decisions quickly. But the biggest decision they're going to make is admission to the hospital. Does your loved one need to be admitted to the hospital? Which means, are they safe to be discharged, or do they think the patient needs more assessment, stabilization, and treatment? If they think yes, they need more assessment, stabilization, and treatment, that's when you'll meet someone like me, your lovely hospitalist, right? But if they say no, we think that they can go home, you have every right to say, stop, I'm unsure. Or if you're happy to be going home, make sure you're getting all you need to go home. These are the things I need to be safe in our home. We can't get antibiotics until tomorrow. Can I get a dose to go home now? Right? We will need a ride, whatever it is. But you also have the right to deny, or sorry, to decline being admitted. And people do that for a myriad of reasons. I am not counseling against it at all, right? People have their reasons for not coming into the hospital. But what I would say is if they are asking you to be admitted and you feel like you do not want to stay with your loved one, sit down and see where you guys can maybe meet in the middle. What treatments are safe to be given at home? Do they have a hospital at home program? Will visiting nurses be able to fill in the gaps? Can you get in with a specialist tomorrow? Right? I have seen families decline admissions for lots of reasons, and none of them are wrong. They all are their reason. But the number one thing I want for you and your loved one is safety. And so if you get to a place where you feel like we're not staying, think about how you can work together to make sure that everybody is safe when they leave, right? Speaking of safety, information is safety. I'm going to say that again. Information is safety. In the hospital, the more information I have about your loved one, the safer they are. I am not a surgeon. I don't own knives. If I had knives, probably should be a little bit scared, right? Those are the surgeon's jobs. The only thing I do is prescribe medications and monitor your medical history. But these are two of the most important things. And that is because the most common error in hospitals are medication errors. Medication errors do not mean that you only get a medicine where you're not supposed to, right? Lifetime movies have drilled that into us, that the only thing bad that can happen is that you get your neighbor's medication. Lack of getting your medication is a medication error. Dosing errors is a medication error. Getting it at the wrong time is a medication error. Getting a medication you're allergic to, is a medication error. Getting medications that interact with each other, that's a medication error. If I don't know the medications that your loved one is taking, not prescribed, notice my words, taking, what you're prescribed and people are taking are often two different things, right? If I don't know, I can't plan. If I can't plan, we can't guarantee safety. So I want you all to be the owners of these two pieces of information, medications and medical history. And that doesn't mean you have to have all of it memorized. It means you have to have access to correct and consistent information, however that access comes. Nowadays, everyone's primary care doctor has an app or a portal. That's great. Pen and paper work, wonderful too. I've seen family members keep Google Drives and everybody updates it. Whatever works for you to get two things, consistent and correct information about medications. That is what I need. Okay. The other thing that's going to happen is you are not going to leave that emergency department until you meet the hospitalist. Do not let your loved one be admitted, if you can, without a friendly face. It's so much more than just telling me their medications and their history. You know that person best. When we talk about pediatrics, we often say, believe parents. My realm is a little different. My patients are a little bit older. The people I believe are their caregivers, the people who live with them, the people who know best what they look like. Is this a good day for mom's confusion versus like a bad day for her confusion? Dad is limping a little bit. Oh, he always does that. Nope, that's a brand new limp. You know this person best. Stay if you can. And I know it's asking a lot, but if you can, stay and meet the admitting physician. Stay and meet the hospitalist. And when you do so, you're going to set up communication expectations. You're going to say, hi, I'm Jane. I'm the healthcare proxy. Here's that paper that I filled out. And we all know I'm the person you're going to call when we talk about medical decisions. So in addition to meeting me, giving me information, helping me with assessments, it's important to meet the admitting physician to set up that initial touchstone so that we know who's who and who needs to be communicated to. That's going to go a long way, and we'll get into that a little later. Get used to repeating yourself. I have a podcast because I lack creativity. I named it after the book. So it's also called Prescription for Admission. But I just did an episode about this, repeating yourself. Sometimes it could feel like, oh my goodness, nobody knows what's going on. I was just asked this question. I was just asked this question. I was just asked this question. Get used to repeating yourself. It's only for your safety, right? They will ask repeatedly, name, why you're here, date of birth. Those are safety checks, right? Um, Asking the same question, the emergency medicine team will ask you, I will ask you, the nurse will ask you. Again, it's a safety check to make sure we're getting the same piece of information. But the thing that I want you to do is lean into this process a little bit, right? Yes, it's annoying, but every time they ask, does it bring a little bit more information up to the front of your mind? Take it as a chance to fill in the blanks a little bit more, to reflect a little bit on what happened. Because oftentimes you end up in the hospital after something bit traumatic happened. You don't know, like your head from your tail, things like that. So, yeah, it might be annoying, but maybe you can use it for your benefit and for your loved one's benefit as a way to just kind of reflect, answer the questions a little bit more. You might be surprised at how answers change over time when you really get a chance to sit back and reflect and answer instead of just answering in the moment. So I'm sorry, they're going to ask a lot of questions again and again, but it is for your safety and it can actually help. Admission time is also the time to start making special requests. And I say that because it is easier to back off of something in a hospital, say, than it is to get something new in a hospital. Okay. Your loved one needs a special mattress. It is easier for us to put in that order on day one than for us to be able to get them out of the bed on day three, right? And there's lots of special requests. People have special CPAPs that they use, right? One of the things that I encourage is ask if you can sleep over if your loved one is prone to sundowning and getting very confused at night because suddenly they're sick, they're in a new place. They may, get even more out of sorts with new faces and voices and beeps and things like that. And so I have had a lot of family members sleep over and help their loved one with dementia, right? It's easier for me to get you that single room with a cot on day one than it is to move things around on day two or three, right? So ask for anything you need early because you can always say, oh, thank you. We don't really need this, instead of having to rush to get it. And the final point on this slide is planning for discharge starts on admission. And people often bristle when I say that. It's not because I'm trying to get rid of your loved one in any way, shape, or form, but we have to think way ahead about what you will need to be home safely. And so we start thinking about those things as soon as you show up. And you should be thinking about that as well. And a lot of the times people will say, if they're going to need X, Y, and Z, we can't care for that at home. Or we're here because we're not able to care for someone at home any longer, right? That's all part of discharge planning. So I know a lot is going on that day, but start thinking about what would we need to be home safely if home is where we're going? If they're going back to their community, what do they need for that? So that's your North Star throughout this hospital stay. Day communication and planning. Communication in the hospital is going to make or break your experience. Communication in the hospital is going to make or break your safety. So communication, to me, is one of the best skills that I can teach you to improve your hospital stay experience. The things that I say, really easy. I want you to think of this mnemonic. I want you to have the ear of your physician, okay? I want you to set communication goals early, E. I want you to set communication tied to an action, A, and I want you to have communication goals that are reasonable, R. So to make sure you have the ear of your physician, you're going to set those communication goals early. Goes back to what I said. You're going to meet me as a hospitalist day one. Hi, I'm Jane. I'm the person who you need to speak to. Here is my healthcare proxy to show that I am the person supporting my loved one legally. And we're going to set up an expectation. You're going to call me after that chest x-ray, Dr. Nugent. Oh, now I have a piece of information that I'm going to talk to you about, right? So it's an action and it's reasonable. This is a hard one for people to kind of balance. It is very difficult work to care for all the patients in the hospital the way that they need to be cared for. And if communication is set up to fail, meaning people want to be called after every med or before every medication, 2, 3 times a day, call my sister and my second cousin, but not my ex-husband, right? All of those things will set up your medical team for failure. Reasonable expectations for communication must be one person at one time, and every piece of communication must drive an action forward. This is not social hour, right? If I'm not speaking to you about a test, if I'm not speaking to you about a plan, what is the point of the conversation? I want you to get every piece of information out of me and give me every piece of information we can. Every conversation must drive care forward, right? The way I plan my day as a hospitalist is that I see my patients after their tests. I see my patients after their specialist visit. Why? Because something has been accomplished and we can make a plan on that thing. Otherwise, it's a social visit. If I'm seeing you before your colonoscopy, what are we don't have anything to talk about to say what the colonoscopy said and what are the next steps, right? And that's what I want you to think about. Every conversation should drive care forward. And that means some days you may not get a call. Maybe the day is stable and we're getting antibiotics and things are moving. Other days it's two calls because we're following up on different conversations. But make sure you're setting the expectation that every conversation is tied to an action so that you can help move care forward. Okay? Case managers and social workers are going to be your linchpin in a hospital stay. They're your bridge to leaving the hospital safely and getting to where you need to be. These are the people who are going to help you organize delivery of equipment, outpatient antibiotics, new specialist appointments, travel arrangements if necessary, living arrangements, rehabs, and can also hook you up with elder care lawyers. They can complete the healthcare proxy form and the advanced directive forms. These people are a wealth of resources. So many resources change in the communities. So many insurance rules change. I, as your physician, will never know. These people, this is their whole job, is to know what's in your community, how to link you up with things, how to get you services, how to maximize what your insurance is doing. I would prefer you spoke to the case manager every day than if you spoke to me every day. And that sounds weird, right? But there may be a time medically, like I said, where we're not doing a lot. But logistically, there's always more planning to do, right? And when you're talking to your case manager and your social worker, be honest. Please tell them the whole truth. What can you take care of at home? What does home look like? What do you need help with? Financially, what is in your wheelhouse? What is not, right? Because those are the people who are going to be able to fill in all those gaps. I have and can make amazing medical plans. And my case managers will come back and say, yeah, that's great, Monique, but like no one's insurance is going to cover that. Oh, that's wonderful, but that's outside of the delivery network, right? I don't know those things. They do. So touch points are really important with the case managers and the social workers. To me, they are my strongest team members in a hospital because they are your bridge to a successful discharge. Now, speaking of discharge, where are you going to go after the hospital? That can sometimes be home or not. If you go home, it might look a little different. There may be new medicines or new pieces of equipment or a new personal care attendant or visiting nurses, right? Sometimes home isn't the place you can go anymore, and that is okay. It is not always possible to care for someone in their home all the time. So, really, this is what I meant by think about discharge on admission, right? Really think about what you need to be at home safely if home is where you want to be. If home is really where you plan on bringing your loved one after discharge, you've got to make that a safe space, not just for them, but for you, right? The last thing you want is to be stuck in a situation where you're asked to do some kind of medical care, some kind of nursing care that you're not able to do, or you're physically, like you yourself are physically unable to perform, right? You as a caregiver have to be safe in your home before you can care for anybody else, right? So think about what you really need to bring your loved one home safely. Senior living communities, rehabs, these are places people may go in and out of, may have touch points with, you may be familiar with. Work with your case manager. Go visit if you need to, if that's where you're going to go after discharge, but think about it. The other thing that hospitals are great for is for a little bit of a timeout to discuss goals of care and end of life decisions. These are difficult and hard conversations to have one-on-one. They are oftentimes not conversations people will delve into by themselves. But me and my colleagues, this is our bread and butter of our conversations. And this is a good time to use us as a resource to say, hey, let's talk about where we're going. What does this decision mean? I'm sorry, this diagnosis mean for how we can live life after this? Does this change what our expectations are around movement, around comfort, around feeding, right? This is a good time to utilize me, the case managers, the chaplains, whoever it is, to have these conversations and readdress all of these things at a time when maybe you're getting a lot of new information about how you might need to move forward with care after this. Day 2 and 3 are testing and treatment days. By this time, we should have a lot of information to make sure your loved one is safe and stable. We'll order more specialized tests. This is when you'll meet specialists, things like this. This is when we're clarifying the plan. If we need to do procedures, you will be asked to sign an informed consent. And this is why that medical legal framework is so important, right? Because you're the healthcare proxy, so you've already signed this out. We're discussing results and plans. Why? Because you've got the ear of your physician, right? Every conversation you're having with me is around an action, something that I've done, a test that I've gotten back, so we can plan and move things forward, right? And what does all this new information mean for long-term care, right? Has prognosis changed? Has mobility changed? Has feeding changed? Have medications changed? Does this change anything financially? All of these things. This is a good time to start thinking about those things. The other, excuse me, thing that I want you to think about is this, and this is often really not thought about until the last minute. If your loved one gets anxious during procedures, if they need a little bit of calming medicine for things like MRIs or CAT scans, if they get confused after anesthesia, do you need to be present to support them during testing, right? We can make that happen. If you, And this is what I mean by ask for special accommodations early, right? If you go in and you're like, I know that mom is not going to get through an MRI without me holding her hand. You're not the first person to ask for that. They can make that happen, right? But the thing you don't want is for tests, vital tests to be canceled because somebody is too anxious and can't tolerate it. So if you need to be present to support your loved one through testing, make those accommodations then so that you get all the information that you need. Days 3 and 4 is what I call the lull. These are the days where now we got all of our information back, right? We're just on a whole bunch of antibiotics for several days, or you're getting Lasix. We know what the plan is. These are the days where the plan is being carried out, right? Use this time to breathe. You just made it through the emergency department. You just made it through an admission. You just held someone's hand through an MRI. You had to give 8,000 people the healthcare proxy papers, right? Take a breath. Can you now activate your social supports to maybe take a break? If your loved one is tucked in and they're safe, can you get a little bit of a break? This is a good time to maybe go home, do a little laundry, get away from the hospital for a little bit of time because discharge is coming up, and that's an active time too, right? This is also the time you're going to use to plan. I always tell people pick a day for discharge and then add a day, right? That's really the day you're going to leave the hospital because it's going to take a while to get the antibiotics in and the IV lines and the oxygen delivered. And then you're going to want your loved one to be seen by physical therapy again before they leave, right? So all this thing that you're having to line up, don't feel bad if you need an extra day, right? Do not feel bad and do not feel rushed. If you feel like you're being rushed, then you need to say that. And the words that you're going to use are your cuss words, all right? C, I am concerned. You, I don't understand. S, is this safe? Right? So anytime you feel like you're being rushed, anytime you feel like the situation is unsafe, anytime you want to stop and put the brakes on the medical team, on the case management team, I want you to use your cuss words, not the SHIT ones. Those ones are bad, but the concern, understand, and safety. These are words that will tell the team we need to stop. We need to readdress. You need to have all the things you need lined up for a successful discharge, or things will fall through the cracks. So don't feel bad if you need an extra day, right? Sometimes you may find, unfortunately, that insurance might need an extra day to authorize things to happen for discharge, right? I know people are often anxious to leave. Sometimes I say maybe this can be a spa day, right? Like if we're all just kind of waiting for insurance to clear everything, maybe you get to take a little bit more of a breath. Um, but don't feel bad. Don't be surprised if discharge takes an extra day, right? And again, just think about what in this hospital stay has changed what your long-term goals of care are. Because now you get to day 5, and day 5 is a very active day. Day 5 is discharge day. This is the day that you have to make sure you have all your medications, your equipments, your appointments. If someone needs a new type of food, right? It's not just low salt or low sugar. People oftentimes need different textures of food as things progress. Do you have the transportation you need? Are you going home by ambulance, by your own car, by chair car, right? What has happened in the hospital? Is my loved one now have a change in their functioning? Do we need a walker or a cane? Do they have one side is weaker than the other side now? And all of this, does this all fall within my capabilities as a caregiver, right? Because we can come up with whatever plan, but if you can't do those things at home, then people will feel frustrated and plans will fail. You have to really do the thing you can do. And there's no right or wrong answer on what you can do, right? I have a ton of families who say, oh, like 8 of my daughters are nurses, so I'm perfectly fine. I'm well taken care of. Don't worry about it. And then I have families who will say, I can't do needles. Like if dad's going home on insulin, I'm not your girl. I can't do needles, right? I can't do home hospice. I can't, we can't do oxygen in the home because my brother's a smoker and he won't quit. These are all real things. In life, we often are given the choice to do the best thing that's possible, right? All the rainbows and unicorns. But in reality, we can only give the best possibility we have. So you've got to make sure that your abilities line up with what we're asking you to do at home. And I find parents are better at this than adult children. Parents of young children seem to be better at saying, whoa, 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 we can't do that at home. Whoa, 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 we're a little bit concerned. They seem to put the brakes on a little bit more than adult caregivers. And I think it's all these years, I think it's that I can do it. I should be able to do it. I want to do it feeling, right? The hospital is there to make sure that you can do the thing you can to the best of your ability. If we're forcing you or asking you to do more than you can do, you're going to really set yourself up for frustration, for failure, for feeling guilty when things don't work out. So please, please, please be as open and honest about your limitations as possible, right? Like I said, some people are great at things, some people are not, and that's perfectly fine. I personally had a situation in my family where someone's caregiving ability was less than what they were discharged with. And it did not end up well at all, right? And it was one of those, she really wanted to do what she thought was the right thing, but it was outside of her ability. And it didn't end well. And so it's something that I really, really am passionate about is let us help you do the best thing you can. But if we're asking you too much, tell us to back off. The other thing that's really, really important and we have to talk about here in these here United States is access barriers. If I'm discharging you with medications your insurance will not cover. If I am discharging you with equipment your insurance will not cover, you won't get it. And then people will get sicker, or people will be readmitted, or people will get hurt, right? And so access barriers are real. Social determinants of health is the phrase for it, to say the way your social situation interacts with your health situation. And so please ask for new medications to be priced before you leave the hospital. The last thing you want is to show up at CVS and they say, guess what? This is $700. And it happens, right? And so access barriers are real. And working with your case manager, working with the social worker to make sure that you can access the things you need after discharge needs to happen before discharge. I have started teaching something called the post-hospital debrief. I don't know if I should trademark that or something, but in healthcare, when we have a bad thing happen in the hospital, right? Let's say a patient was injured, they fell in the hallway. We do a debrief where we stop and we say, how did we get here? Like, what happened? What did we do well? What did we do poorly? What did we do afterwards? And how do we prevent it? I think this is a really good thing to bring into our homes after a hospital stay to say, hey, what happened? How did we end up in the hospital? Was it because we ran out of medication? Was it because there was an unsafe situation in the home? Was it nobody's fault, right? Um, was it something that we saw happening little at a time we could have intervened on? So it's really important to kind of try and unpack what happened that led to a hospital stay, right? And then do the same things. What did we do well? Were we able to rally as a family and get all the things we needed done well? Did we have the healthcare proxy advance directive ready to go with the MULS form in that folder that's on the refrigerator? That worked out great. Kudos to us. We'll keep doing that, right? And what did we do poorly? Right? Did we have to call 18 different people? Did we not know where to find any of the documents? Did we end up in a hospital we didn't know or weren't expecting to be in that's far away from like dad's cardiologist, right? And then where do we go from here? How does a hospital change our goals of care? Do we get a new diagnosis? Do we have new changes in prognosis? Do we have new limitations? How does this change our social situation? Are we still able to live at home, or do we need to think about another living situation? Do we need help in the home? Does it change how you as a caretaker have to function at work, right? Financial planning. Hospital stays do not come without a financial implication. And it's not just the hospital bill. Oftentimes, it's things that happen also afterwards. Will you need access to different specialists? Do you need surgeries now? Right? Are there new medications that are expensive? So thinking about the finances of a situation are really important. And then update your documents. This is a great time after a hospital stay to revisit that MOLST form. Again, in Massachusetts, the hot pink form, and say, does everything still align? Do we still want those things? Do we still want chest compressions? Do we still want intubations? Do we still want dialysis? All of those things. It's a great time to readdress all your documents. Is the advanced directive still the things we want? Can I still carry everything out as a healthcare proxy? Or do I feel I have to be relieved a little bit and it goes to X, Y, and Z, you know? So it's a really wonderful time after, well, not wonderful, but it's a really poignant time after a hospital stay to readdress all of these things because readdressing all of these things really sets you up to be able to be successful and stay out of the hospital. But also, if you ever need to be rehospitalized, if your loved one ever needs to go back in the hospital, you are starting off with a stronger base than you had before. So that's me and my work. Like I said, really high overview of the things I want you to know. All the specifics are in the book. And if you like listening to podcasts, I also, like I said, I have a podcast named after the book. It's really focused on the experience of caregivers right now. Earlier episodes were more like, what's a hospital and who works there? But now I really reconfigured and really focus on giving you all the supports that you need. I'm really bad at YouTube, but if you like watching it, it's there too. So please like and subscribe, as well as you can find me on Instagram as well. And then next week, Tuesday, I will be doing this again a little bit more in depth and introducing more of the resources that I have that people can take advantage of to really set yourself up and your loved one up for success through the experience of being hospitalized. So, thank you again for inviting me into your space and for listening to me. I appreciate this. We have raised hands. Kimberly.
Hi. I just had a question. Okay, so my mom is 84. She was diagnosed with Alzheimer's, and she'll be with me for 2 years in June. Um, I do have a durable power of attorney, I don't have a proxy. I don't have an advance directive, but I can get one. But she's been in and out of the hospital, and I guess they're using that basically like a proxy because I'm the only one, I'm the one
Mm.
makes the decisions for her. So should I still get the proxy and the advance directive? Because I'm about doing things in order and
Yeah.
having everything that I need. So should I still get the proxy and the directive?
So each state has a different law surrounding who makes decisions and how, right? And so it often goes because legally, like if someone gets hit by a car and we don't know who they are, we don't let them just have no decision maker, right? So in the state of Massachusetts, we call it the hierarchy of decision making. And so if you present yourself as the caregiver, then it is often like assumed that you are
Mhm.
the person making decisions. It is not 100% legal, right? There are people who can come back and challenge that. I have seen very messy family dynamics where that happens. So if you can get the healthcare proxy signed, I highly suggest it. You do not need an advance directive 100%. The advance directive will do nothing but strengthen your voice. But if you are her decision maker and you know the things that she wants, what she values, and how she wants her care to go, then you can act as a healthcare proxy without an advance directive.
Because I did ask her prior to her declining what she wanted, and she did tell me. So, but she has since declined. And I know you have to get things notarized, and if she's not in her right mind, you can't get her to sign those
Right. So
things.
you can make a healthcare proxy, the legal, I don't want to say limit. I'm not a lawyer, so I'm sure I'm picking the right word, but the legal like threshold for a healthcare proxy is different than that for an advance directive,
Okay.
right? So somebody with dementia can still make the decision about who they want to speak on their behalf,
Okay.
in certain settings. So if
And
they
the-
find that her dementia isn't playing a part into that decision, right? And dementia is complicated. Sometimes people have good days and good moments and bad moments, right? Um, but it doesn't preclude them from making any decision at all. So you can get that.
and the proxy is only given if you're in the hospital.
No, no, you can fill out a healthcare proxy outside of the hospital. But being in the hospital does give you access to get that done a little bit more easily.
I can get it from my PCP, her PCP, or
I would say ask them. I
okay.
don't want to speak directly to them, but an elder care lawyer, and your state, check out your state's, like a council on aging. They should be able to point you in the right direction as well.
Mm.
And then I would also say check out the American Alzheimer's Association. They can also, point you in the direction to get some supports with that.
And I don't want to hold up your time, but like when she started to decline, I went to go get her and move her in with me. And 3 days after I moved her in with me, she was complaining of pain in her stomach. And we went to the emergency room. And they triaged her and they're like, oh, she probably just has a stomach bug. Oh, we'll let the doctor see her, blah, 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 blah. And I said, no, I want you to check her for an aneurysm. I want you to check her for everything. And they were like, oh, that's just stupid. She just probably has a stomach bug. She just came from another state. And I told the doctor, ER doctor, I said, can you just check? Because the way she's describing her pain sounds like an aneurysm. And sure enough, Monique, she had an aneurysm,
So you advocated. That's what I
and
mean.
it was
Yes, good
ready,
job.
getting ready to rupture, and they rushed us to another hospital where she had surgery. So yeah, it's been a
Good.
long years.
It is. Yeah, it's not easy. It is not easy. And like I said, it's to me it's just very strange that we preach the believe the parents thing in pediatrics, but when it comes to adult patients, we don't kind of preach that same idea of believe their caregivers. When I teach, I definitely teach into that. So use your voice and advocate. Thank you so much, Kimberly.
I have a question.
Yes.
Yes. Actually, what Kimberly said, my mom had two blood clots, and the paramedics, this was 2 years ago, wanted me to bring her back home, even though she was in pain. It ended up being she had emergency surgery 6 hours later in the ER. So it's crucial to advocate for our parents. My question is, I'm in California and I'm the main caregiver for my mom who's going to turn 94. And I have trigeminal, which is excruciating facial pain. Do you know of any resources available to help caregivers that are in chronic pain?
I'm so sorry. I don't know anything specifically about that.
Yeah.
Um, what I would suggest there, Medicare just started, well, not just, maybe about a year or two ago, but they started paying for healthcare like navigators.
Uh-huh.
And so that might be something helpful to kind of take things off of your plate a little bit so you can focus on what you need to. So if you have somebody who does the coordination of your mother's like appointments and transportation and things like that, if that gives you a little bit of headspace to be able to care for yourself.
Well, I
But
have 9 siblings, so what I did is I actually divvied up the tasks. She lives with me. So one goes to the cardiologist with her, another one goes to the pulmonologist with her, another one goes to the primary doctor, and then I give them each a day where I say, You need to come to my house and take care of my mom for at least 9 hours." Some do it, some don't do it. I'm having a problem right now with hygiene. So I gave one of my sisters, you are tasked to keep, the hygiene. She hasn't taken a shower in 2 weeks. So I said, it's your job.
yeah,
I can't stress out over it.
that's good. That's really good.
But
Bring as
how
much
do you
support
deal
as you
with
can.
somebody that doesn't want to take a shower?
That's a very specific and different topic than
Yeah.
hospitalization.
I don't want to take
But
any more time.
there are ways, specific ways to help patients who have dementia with their hygiene practices. Um,
Uh, what we
yeah,
can do is set up a Zoom where we focus on that. And so we will send out something soon.
Okay, thank you. Yeah, I would appreciate it.
You
Thank
should.
you. Thank you. This was very informative, by the way.
oh, good. Thank you so much.
Thank you.
Is that Lisa's hand next?
Yes, it is. Thank you very
Okay, perfect.
much. Yes, just allow me to introduce myself. My name is Lisa Davis, and I'm here in Philadelphia, and I recognize that I'm in the space of dementia caregivers. Uh, I am not a dementia caregiver. I am a family caregiver for both my husband as well as my mother. My husband is a bilateral below knee amputee, in addition with dialysis. And my mother is just becoming the person who, dare I say, is aging. So here
That's a
we
real
are in the
thing.
middle. Yeah, it's a real thing.
Yes,
And
yes. And dementia is
it's a
not the
real
only
thing.
reason we care for our loved ones over time. So
Exactly.
I understand.
Exactly. And I just really want to comment, not so much as a question, but I've been advocating, more importantly for my husband, for numerous years. But I'm glad to hear this information that you presented, just coming out of a hospital stay for him, literally 6 weeks ago. We're now in the stage of home care where he's getting therapy and such. And some of the things that you've described and explained, I've been doing, I'm going to continue to do, very helpful. But there are some things that you pointed out that I was not aware of that I definitely need to raise the ball, if you will, or raise the bar on to make sure that we have certain things in place. But more importantly, and this is for all of us as caregivers, advocating for our loved ones is the absolute most important thing we can do to help them, but also advocating for ourselves. what is it that we can do in the home, and be honest with the doctors and or specialists what we can and cannot do. Because the reality is once they come home, it's on us.
Yeah.
It is definitely on us. And we all want to wear that cape and be that hero, but the reality is we don't want all this work. And if we don't speak up, then we're not helping our loved ones. We're making things that much more challenging for ourselves. So thank you for pointing that out. Thank you. Thank you
Anytime,
for,
anytime.
yeah.
Thank you.
Mm-hmm.
I'm trying to find the other raised hands. Nicole.
Hello, thank you so much, Jacqueline and Monique, for hosting this evening. I'm a family caregiver, and I'm just really uh, not overwhelmed, but just feeling very grateful to have kind of a linear step-by-step process to kind of keep me encouraged and motivated to continue this journey with my mother. She had a really rough hospital course.
Mm.
Couple of years ago, she was discharged with surgical sepsis and was able to survive that, and is a kidney dialysis patient. And I would have loved to have known kind of just the forms that I could have presented in the different hospital situations where I feel like I could have been taken more seriously and utilize your cuss.
They're
That
good
that yeah,
words.
that would have really come in handy. But there was one question I'd had. You had shown a website with a map on it where we could download those forms to fill out, and I just wanted to get.
Yeah, let me get that link for you and I'll put it in the chat right now.
Thank you
But that
so
is
much.
the pulse form. You should be able to get that form from your primary care doctor. Every hospital will have them. But they look different depending on the state that you're in.
Okay, thank you.
You're welcome.
Thanks again. I really appreciate it.
Oh no, thank you for coming out. I appreciate having a chance to talk to everybody. Tara. Ooh, did we lose you, Tara?
No, sorry, I couldn't find the mute button
Oh,
because,
there you go.
Zoom. Hi. Hi. Yeah. I just had a quick question about the requesting special things on the first day.
Yes.
Um, is there certain people that we should be asking for certain things, or is this kind of in the lines of just keep repeating and then hopefully somebody will like for example, like rooms or even special equipment or even after like, I guess towards the end on, day 3 or 4 where you kind of know what our loved one needs when it comes to like assisted tools, like should we be asking a specific person to follow up with things like that?
Yeah. So, day one, ask your admitting team, right? Ask the admitting nurse, the admitting physician for all the special medical things you need, the CPAP, the type of mattress, the type of chair. If you're going to spend the night, if they need to be fed by hand, if they need to be fed by you, all of those special things, ask the medical team for. As time goes on, and you were asking about special like adaptive equipment, they really should be reassessed by the physical therapist and the occupational therapist during that hospital stay because they may have some changes in their function that might require new equipment. And you want that equipment to be covered by insurance. And the way you get that covered by insurance is that the insurance agency will look and say, did the physical therapist say that they need this? And was this prescribed, right? So as if you're concerned that you're going to need different adaptive equipment, ask to have them assessed by the occupational therapist and the physical therapist. And then when it comes to speech stuff, speech therapy doesn't just do language, they do swallowing. And so if there are concerns that your loved one is not swallowing safely, like you notice they kind of choke on things or the nurse notices that, have them be seen by the speech therapist to reassess their swallowing needs. Awesome. Thank you, Tara. Trying to go through the chat.
There is someone with a question. Okay, so we have someone who has their hand up.
I don't see them. I lost them.
That's okay. Uh, ask it.
Okay. Hi, I'm Lynn, and I am Jacqueline's partner in the Care Den. This has been so incredibly informative and so impactful. Thank you.
Oh, thank you for having me.
I have a question for you that sort of comes from that experience that I think many caregivers have, where they come into the hospital and they're like, you have all the answers, and also I don't trust you, right? Like there's this um, dynamic that some of us have had, whether it's true or not, or it was just a felt lived experience or emotion. Um, this is an odd question, although perhaps you've heard it before. Um, as someone who cared for my father with dementia, I had always heard anecdotally one night in the hospital is going to equal a week of recovery. Can you comment on this? I know it's like a wives'
I
tale.
even wrote it down. I even wrote it down in the book.
Okay.
Yes.
Oh,
One day in the hospital, I want you to expect it to take about a week to get back to normal, right? I say that to and not just people with dementia. I say that to my 22-year-olds who come into the hospital. Why? Because the hospital is a very intense experience of deconditioning, right? And when we talk about our older patients, we talk about medically frail patients, deconditioning also causes worsening of mental status, right? And so a long time ago, I read the study, and if you asked me to quote it today, I couldn't. But I remember the point of the study. They had taken a bunch of football college players, so young guys, peak of their like physical experience in life, and they put them in a hospital bed for 7 days. And in 7 days, they lost 50% of their functional capacity, right? So it's a very, very deconditioning, very confusing, very mentally draining situation for a 20-something-year-old. Now imagine you're older, your brain isn't normal, not just from dementia, maybe from a couple of strokes, from taking medication, from sepsis, right? You have chronic wounds, things like that. It's extremely debilitating. And the term for that is post-hospitalization debilitation. We're really familiar, I think people think of it more in ICUs, right? So people will talk about ICU deconditioning, but it's not just ICU deconditioning. Hospitals deconditioning is a true thing. And so, yes, it's one of those, I don't know if you want to call it hospital wives' tales. Um, there's no hard study, but it takes a long time to feel better after being hospitalized. And so we do usually say 1 week for every day that you were hospitalized. And some people may never get back to their prior functional capacity, particularly our older patients or patients with underlying brain disorders. We have what we call a stepwise decline, right? They're doing really well, something happens, they go down, then they get back up a little bit, but it wasn't where they were before. So this is the new baseline. Then something happens and we see this little stepwise decline, right? And that's why I say the hospital is a great place to have conversations about goals of care because those change and they should change, right? What you're trying to accomplish at 45 years old with your healthcare should not be what you're trying to accomplish at 95 years old with your healthcare, right? So these conversations should change as you get different diagnosis, as you figure out what your values are, as you figure out what your like abilities and your hopes and goals are, right? And the hospital is a good time. If not, have that conversation with me, have that conversation as a family and say, Where are we going from here? And what does this mean for the long-term plan?
if I could just ask one follow-up to that. If if I am hopeful that the person that I'm caring for is discharged, but they do have a debilitating disease, and really what I want is thank you for helping us heal him from the food poisoning, but he's not going to get better.
Mhm.
Do I need to just say our goals of care are comfort? So let's
Yeah.
take care of what we need to here and exit as soon as possible. I mean,
So, so if your goal of care is comfort, comfort means a lot of things, right? I have prescribed everything for comfort for from end of life, like legitimately helping someone pass away comfortably, to surgeries for comfort, right? I had a patient a couple months ago who we took out his gallbladder because though he wanted just comfort, his gallbladder was causing him a lot of discomfort. And so that was how we were able to help him be comfortable. So palliative care is and comfort is very different from hospice care, which is active end of life care. And I'm happy to come back and talk about the difference between the two and how we can navigate that. But if your goal is comfort, right? Comfort is a spectrum. Tell me that because we can work on that spectrum. And it also will help get you resources to be able to continue focusing on comfort at home if home is where you're going.
thank you.
Thank you.
If there are any more questions, there was one. Okay, I commented under the Instagram post, but I was wondering if I guess anyone had advice for when people have negative experiences when patients try to ask for a patient advocate and we're denied.
Oh, wow. So if you were denied access to a patient advocate, which you should never be denied access to a patient advocate, that is a case for the Department of Public Health of your state to review. Um, Patient advocates, they are employed by the hospital. You should understand that. They are employed by the hospital. Their job is to help you navigate the situation. They are still employees of the hospital, right? They have access to more things. They know more people. They know how to smooth situations over better than you will be able to. You should never be denied access to uh, a patient advocate in the hospital. There are a lot of services that call themselves patient advocates um, that may or may not be billable, right? So I know that some of them may want to bill your insurance, and if your insurance says no, then they will not service you. But if you are admitted to the hospital and you are being denied access to the hospital's patient advocacy division, right? That is a cause to have that discussion with your state's Department of Public Health.
Thank you so much, Monique. I do think that that is our final question, unless anyone would like to come off of mute real quick and say anything else. But
Well, thank you guys so much for having me. Please, um, I've created a resources really with you all in mind. And like check out the book, check out the podcast, and comment and let me know what I should be covering in the podcast. I really want to make sure that I'm giving information that people can use. And I dropped the link to my master class where you can, this is the first time I'm doing something like this. Usually I do these our community events and kind of private like this. And so this is the first time I'm doing this for myself and that I want to bring people in and give people resources directly from me. So check that out and register and check out all the resources on my webpage. Is that yeah. And we will hopefully keep in touch. This has been fun, guys. Thank you so much. Thank you, thank you. And thank you for caring for your loved ones and being partners in care during their hospital stay.
this was so insightful. I appreciate you very much, and we're going to partner again at some point because this. I love you. You're
This is
great.
great.
All right. Thank you everyone for showing up. Thank you everyone for caring for the person that you care for. You are the reason that they are here, and caregivers are the backbone. So we shall see you plenty in the future.
Great.
All right.
Thank you.
Thank you.
Thanks again.
Yay.
Oh, my nose.
Do-do-do-do-do.
Ugh. Oh my gosh, my nose was running the whole time.
You were so great. Okay. Let me have 5 seconds. I'm
Yeah.
gonna clear us out and stop the recording.